Oh.
Yep, she's here.
Oh, good.
And we are now officially recording.
Great. Hi, everyone. We're going to open the meeting of the Needham Board of Health for February 12th, being conducted by Zoom due to the Governor Baker's executive order, March 12, 2020. We'll do a roll call vote for everything. So I'll call your name, you'll say yes. So I'd like to start by, let's see, meeting materials were released previously. We won't be open for public comment, but written comments are always welcome. And let's see, I'll introduce each of the board members and just say, yes, so we know your voice. Ed Cosgrove.
Yes.
Rob Partridge.
Yes.
Steve Epstein.
Yes.
Christina Matthews.
Yes.
Okay. I'll introduce staff too, just so we know who's who. Tim McDonald. You're muted.
Yes, here.
Okay, Tara.
Here.
Karen, Shannon.
Yes, hi.
Hi, Tiffany.
Here.
Hi, Diana.
Here.
Lynn.
Yep, here I am.
Carol. I'll go to Hannah. Hannah, to say yes, that's fine.
Yeah, here.
Okay, thanks. Carol's here but muted, or appears to be here. Okay, so we will move on to the agenda. So we had meeting minutes from 2 meetings, January 14th and the next meeting, which is 2 weeks later. I don't have it in front of me. There it is, and the 28th. Did any board members have comments on the meeting minutes?
A couple of comments. One was that I think my last name throughout the minutes is spelled with 2 T's and it's just 1 T. And I think on our last meeting minutes, there was a portion under Tiffany's piece where she was talking about, let me see if I can find it real quick. They were talking about the contact tracing, and I think the way it was said was it takes about 5 or 6 hours or something, but it didn't seem like there was something left off at the end of that or something. Did that mean 5 or 6 hours per case? And I thought that was a pretty good, important piece to kind of clarify the amount of time they're spending on each case.
So it probably was split between the schools and the regular. The school cases each take 5 to 6 hours, and then a regular case can take about 2 to 3, depending.
Okay, maybe we should say that in there, 5 to 6 hours per non-school case, or that's a lot of time.
Okay. On the January 14th minutes, I just had an edit, we were talking about testing in the schools, and there's an $800,000 price in there, which says for a 2-week period. That would be for the rest of the school year after this free 6-week period that the state testing. So that sounds really expensive for 2 weeks. So just say for the remainder of the school year, that would be my edit. So any other comments or edits? Okay, can we have a motion to adopt both sets of meeting minutes?
I'll make a motion.
Okay, I'll second it.
Okay. All those in favor, Ed,
Aye.
Christina,
Aye.
Steve,
Aye.
Rob,
Aye.
Kathleen, aye. So we'll accept those, move on to the next items. So that moves us to staff reports for January. And we are starting with environmental health. Are there any sort of high level things we need to discuss here?
So I can go over a few of my highlights. I'll just review 3 of them. If you have questions, you can let me know. Good morning, everybody. So one of the main highlights I've been busy working on has been helping out with setting up coverage for RRC due to the increase in phone calls that we've been getting. So I've been basically coordinating staff schedules. We brought Kim Parsons back on full-time as far as she was able to coordinate with Stacy. And she was able to put more hours towards us at this point. I know they're going to be starting to gear up. So Kim is there. And then I was able to get help from Dawn to bring Jane and Mo back to cover, because once we released those phases from the governor, our phones were ringing off the hook and we were getting a lot. So we had to move in that direction. The other piece that's happening is that we just found out, and Katie King has been critical in getting a hotline set up for our building. So there'll be dedicated lines now. 5 or so lines will now be dedicated for this hotline, so it won't impede on our current existing phone lines. So I'm working with the building facilities department, as well as a connectivity person that deals with our phones, and we're incorporating a new phone system. We're going to be discussing it this morning around 10:30, 11 o'clock after our meeting, and we'll see how that goes. So that will be exciting. And then we'll probably be bringing in some part-time library staff to help cover that line once that gets up and running. So hopefully we'll be able to balance that out when we get those spike in calls. Even around our clinic time, we also got a spike. So that will help ease the phone line issue that we have at the RRC building. The other piece that I want to discuss is a couple highlights are as Residents Inn. I can give an update on that one. Basically, we are at the point now where the room has been professionally cleaned and sanitized and disinfected. And we did get an update back from Springwell that this occupant is receiving home health care services. I think it was 3 days a week, which is what we pushed for. They can't give us an update on how long they'll go on for and this and that, but that's good that that's being taken care of. And then Diana and I will be going back into the room next Wednesday to sign off on the older room, the existing room. She is still in another room at the Residence Inn, but we're going to keep pushing for there to be a long-term housing plan for that individual. So that's the news on that front. And the last one I wanted to cover was Costas. So I know you keep seeing them on our report every month. He's definitely a thorn in our side, right, Diana? So I think at this point, and I talked to Tim about it, we're going to forward this latest concern to the Department of Labor Services division at the state. And they have said that they can take on any difficult or challenging type, situation. So I reached out to Michael Flanagan on that, and he was happy. He's like, yeah, we'll forward it. He gave me another email to send the latest complaint to, and he'll see if he can have one of his staff out there to talk with him. I'm thinking having a more of a state or, agency go visit him and remind him of these ongoing issues that you just have to keep up with it. Keep wearing masks, keep washing your hands, stay socially distanced. And my whole thing was to have him, I know he's medically exempt, which is fine, but maybe not him be the forward-facing staff covering the register. Have one of your masked, people cover the register so that you're not exposing the public. So that would be hopefully the message we want to just portray for him going forward. So that's where that stands. So if you have any questions, let me know. If not, Diana, you can take on from here.
So we also, technically we should have probably brought this up at the last meeting, but we received 2 Fda grants totaling just a little over $22,000. So we're hoping with the vaccine rollout, maybe we can start moving our focus a little bit more away from COVID later in the year. Hopefully with this money, we'll be able to hire another consultant to help us with the restaurants. We're looking hopefully to do a wide training, kind of similar to what we used to do, probably would be held over Zoom, just to kind of refresh our food establishments on proper food safety practices, because I know COVID has been the focus for everyone. So it's kind of getting them back into where they really need to be concentrating on. So I pulled out from our inspection program all the violations that we got in 2020, although there were less inspections overall, of course, because of COVID, but just seeing what the top hits were. So it was just focusing on sanitizing, cold holding. So we know what topics to tailor those trainings for. So that's what we're hoping to do. And then with the money, we also would be able to hire another intern. So Paige Lambert, her last day was the end of January. So we're looking to hopefully hire someone in the next coming months, couple weeks. We'll get that together so that they can continue that work on the FDA standards or any other projects we may have as the environmental health team. Try to think. I feel like this month and last month we're having a little bit of an increase in housing complaints, but we're dealing with those as they come. But yeah, so that's the overall view. I don't know if anyone has any specific questions for us.
Any board members have questions?
No.
I don't want to drag things out, but I had a question about, we submitted to the planning board information about relocating a cooling tower at North Hill. And offline, I'd love to get more information about what, or at least see what we submitted and what our concerns were and stuff, because that actually can be a really important exposure point. You know, Legionella is my thing. Okay, so that's good for environmental health. Oh, and I don't know if are we aware that Bertucci's is also running a ghost kitchen for Guy Fieri?
I saw that online, but I don't think the Needham location was one of the ghost kitchens.
Oh, they're not actually cooking out of there. Okay, yeah, I don't know. They deliver it, so okay, it shows up on the website, but I just wanted to make sure we knew what was happening.
Well, technically, I think it would be fine because it's a commercial kitchen, so it's
Right.
still preparing food just under a different menu.
Right.
But I'll double check to see the Needham location, what they're
Okay,
doing.
and we don't approve menus per se. It's just, you know, the processes and things. Okay,
Yeah.
Great. Thanks. So we'll move on to traveling meals, I guess. Looks like steady and busy, and it doesn't look like Mary Ann's here, but
No.
any questions
She
from
was-
board members?
She was gonna join. I don't know where she is, but
Okay.
Looks like it's actually dropping down, which is kind of surprising. You know, in a time of COVID, I would expect it to remain elevated above last year.
Yeah, it's interesting.
Yeah, especially since people are less likely to be relocating to warmer climes
Mm,
because they can't.
mhm. Yeah, interesting. Okay. Lynn, any update? Looks like you're busy with grants, annual reports, and plenty to do. Okay.
No, nothing to add.
Okay, sounds good. All right, I guess we're on to Tiffany.
Morning, everybody.
Okay.
So I will just do a quick nursing update, and we'll do the COVID as usual afterwards. So 2 Hep-B's this week, 1 Lyme, or this month, 1 Noro, and 1 Salmonella. And I don't actually have the data for those, so sorry about that. But I do know that we were contacted by the state just this last week, so it'll be in February's report about a Salmonella outbreak. But Hannah is working on that, so I don't have the details specifically on that yet either. So we'll keep you posted next month on that. And then I'm just going to go ahead and jump into Talib's because he's at the clinic right now working that with Hannah. So I'll go in there with him. Talib has been extremely busy and is amazing for us. And he is working very closely with our NC8 MRC coordinator, Karen Contador, on getting people in and accepted as Needham volunteers. And as you can see, if you look at his slide, we have increased by 242% since November, which is awesome. And even after our clinics this last weekend, we had several people say, hey, I loved what you were doing. I'd like to help. So we're working on more people, which is great. I got an email this morning that we have 138 pending for all of NC8. So 109 of those have wanted to volunteer for Needham, which is awesome and is going to continue to help us with our clinics. So, so that's our quick update, and we'll get into more later.
Great, sounds good. I know, it's amazing.
Okay.
Do you have a question?
I just-
Sorry.
I just wanted to thank Tiffany and Talib for all the work they put into that vaccine site. I went through it last week with my wife, and it ran perfect. So,
Thank you. Appreciate
and I've
that.
gotten lots of positive remarks from people I know as well.
Thank
Yeah,
you.
I think we got something sent to us as board members yesterday from a member of the public complimenting the clinic.
Right, I saw that.
Awesome. Thank you.
Tiffany, I've had a number of people ask me about volunteering for the Medical Reserve Corps, and I've referred them to the Department of Health. And one or two of them feel like the process didn't move forward. I was just wondering, where should I send them to? Where's the best place?
So you can, if they want to do NC8 or Needham specific, send them to Talib. Go ahead and send out Talib's email. And he is very good with Karen to get people in and out and getting set up. We actually had somebody send us an email about the same thing, that if they go through the main page, they don't really seem to hear back. But when they've come straight to us, then they've been able to get through. So if you just shoot it to Talib, I can have Tim forward you guys his email and stuff so that you've got it.
Okay, thank you.
You're welcome. Thank you.
Great. Let's see. So on to Carol, I guess, if you want to give an update or if there are highlights to discuss. But maybe she's not on. Okay, there you go.
Hi,
Hi.
I'm listening to the state call, so I'm going to try to
Yeah, it's hard. Yeah, it's a tough time.
turn that off, and I'm sorry to
It's
the
okay.
burden of and the gift of technology. Hello. I know you have a lot on your agenda. Tim, would you, and sorry for the son, Tim, would you want me to just talk about the mass support program or wait till later on that when Karen talks about mental health? I don't know how you want me to proceed with time.
I think you can mention that now, and then, after Karen, we can also talk about the STOP grant too.
Okay.
And Karen does update.
So Karen and I have been partnering. Tim resubmitted with the opportunity through SAMHSA, and I'm sorry if my hearing isn't that well with this background. And Tim was awarded a grant that was submitted in 2018, Stop Sober Truth in Preventing Underage Alcohol. So it's a total SAMHSA alcohol focused initiative, and it's $50,000 a year over 4 years. And the score on that application was 81, and that at that time it wasn't enough. Tim got an email that they had reviewed applications and had a funding stream. So Tim resubmitted with the change of contacts with Karen, Shannon now being the program director. So Karen and I have been talking. That funding starts April 30th, May 1st. And again, $50,000 for 4 years. And what we had put in the grant were community level access and availability strategies, like really committing Needham alcohol licensees to attend TIPS training through the SAPSI grant. There were 8 of us that became TIPS trainers, so we can teach Needham alcohol licensees, and give them certification. And that would be free of charge. And it's a 5-hour program. You've all heard me talk about TIPS, as well as alcohol compliance checks more consistently to be able to have data that tracks sales to minor violations and perception of risk and harm, with really having the schools and even in the middle school level support the alcohol EDU curriculum, which is an online program that has a pre and post test and outcomes report. So I don't know if that was the order I was supposed to do, but I've been busy. I've been trying to maintain my connection with the CCIT and Lieutenant Baker. And we just had our community partners meeting with Newton Wellesley Hospital, Dr. McSweeney from BID, and other partners along with our core team. And there was some really good data that Newton Wellesley shared, which I can get to Tim and he can share with you on admissions for Needham and what coding they were seeing. And we really appreciate the fact that they're trying to track for us youth and adult mental health and substance intake. And along with that, we had a new social worker that has been hired through a combination Needham and Dedham partnership. It's born out of the jail diversion program through the Department of Mental Health. And her name is Kim Kitters Montoya. She's embedded sharing her time between Dedham and Needham police departments. And what we've been doing is having some Zoom meetings with her supervisor, Amanda Rutherford. She works closely with Dave Forte, Lieutenant Baker. In her model, even though we didn't write it through the DMH grant process, it is followed through the emergency services program of DMH. She has access to electronic medical records and can have real-time bed placement and scan. So the goal of having Kim is to be able to cut down the time our social workers who are so committed have to find out what's happened with people, certainly through the lens of acceptable information sharing. But the goal of that is to build the relationships with the CATH social workers, Jess, Carrie, and Kristen, Sarah Shine. So across the lifespan, Kim is working in the police department, but she's able to, since she's in emergency services, DMH Riverside social worker, she has access to the electronic medical records. So we're trying to get her to be comfortable with who we are in our CCIT model, because we understand that the town expects us as stakeholders to break down those silos and be able to streamline when residents have either acute or chronic issues so that they don't fall through the cracks. I can stop there.
Do any board members have questions or comments?
No, no.
Okay. Let's see. Okay. So I guess we're on to substance use prevention with Karen. Hey.
Morning, everybody. Not too much to report this for the month of January, but I am happy to report that our vaping grant is moving ahead nicely. We have the launch of the cessation program promotion into the high school. And our vaping grant coordinator, Angie McDonald, has made a brief video presentation that she is now using to help promote and educate administrators, faculty, and staff about the program, with the idea being that if the adults at Needham High are familiar with the program, they can add it to this resource to their toolkit for helping youth students at the building, and have this as a ready reference for students if they're interacting with them, and refer them to the program. Just as a refresher, the cessation program is implemented by the school nurses who we had trained last fall. So it's a one-on-one motivational interview-based cessation program. We've also been starting to network with different groups affiliated with the high school so that we can get their input for the best way to promote the program to different groups. For example, we met with the director of the METCO program, Joanne Allen Willoughby, last month, and her team to share the news about the program and ask for input on the best way to promote across the families from the METCO program and the youth as well. We've also reached out to the Needham Housing Authority, for example, different groups that we want to make sure that have all the knowledge they need to access the program. So we're pleased about that. And then just quickly on other initiatives, our Salsa youth are really moving along and getting trained and empowered in a number of advocacy issues around prevention. And I would say probably right now, the biggest involvement they've had is with the 84. You may have heard me talk about that before. It's the Mass state-wide anti-tobacco youth initiative. So we're really pleased that our Salsa students have been attending a lot of those programs and learning a lot about how to promote messaging and advocacy for tobacco prevention and nicotine into vaping. So that's about it. I'm going to be sharing a few other things in a few minutes, so I'll stop there.
Okay, great.
Karen, can I ask a quick question? Do you have any sense of if the school cessation program, has there been any uptake? Any kids signed up?
So far, we've had one student work with a school nurse, and that student was referred by her guidance counselor. And my latest update from the nurse is that this person has stopped vaping.
That's
But
good.
we're hoping to see more students come forward, especially since the program is free, it's
Mhm.
voluntary, and it's confidential, which
Right,
we know is really important.
Hi, is there a way we could get to see that video
Mhm.
presentation?
Oh, absolutely. I'd be happy to share that through Tim, and we can
Okay,
do that. For
good.
you.
I wonder if the vaping program has been shared through the cessation program, sorry, has been shared through the high school PTC emails or anything, because I think that would be a useful way to.
Absolutely. We plan to have sort of a multi-prong approach to not only the people who work at Needham High School, but the parents and families as well.
Okay.
Yes, absolutely. Thank you.
Okay, thank you. Okay, so now we're on to, I guess, presentation for mental health. Is that where we are? Substance misuse and mental health. So I don't know what this agenda item is about. It looks like there's a presentation.
So what's the best way to share those slides? Is that something you can help me with, Tim? I didn't cue them
They're
up.
actually, they're in the packet.
Mhm.
Okay, there we go.
Here we go. So Carol has already mentioned a few things about the community level efforts around substance use and mental health for youth and adults across the lifespan. I'd like to just share a little bit in terms of the past 10 and a half months, how substance prevention has been working in our community. So since the start of the pandemic, our work has been pivoting to meet the needs of youth and the families that we serve. And we can go to the next slide. Thank you. When the stay-at-home orders forced the schools into immediate distance learning last spring, the dramatic changes to our youth's daily lives would invariably manifest in a range of ways. So how has life changed for youth? Before the pandemic, we can remember that everything was in person for them. And that was the way that adults had eyes on our youth's behavior. So whether, yes, we know parents have their eyes on their youth, but it also included teachers and coaches, employers, clergy members, healthcare providers, all these different adults who interact with youth were able to really have a pulse for what student behavior was like. And we also know, obviously, socializing in person was what seems like a distant memory, was something that was just so readily available to our youth, which they need. But now in our new normal, our view on students is largely digital. We see them through Zoom calls, through their hybrid learning program. Yes, some of them are choosing to do in-person learning, a good number of them, but a number of students are still on Zoom. And that digital view of them makes it a little more challenging to actually know what their behavior is and how they're doing. And of course, for a number of students, that social isolation is a huge factor when we talk about substance use and mental health concerns around our youth. We'll go to the next screen, please. Thank you. So in our work, we largely rely on data. And you're probably familiar, the Metro West Adolescent Health Survey provides us with the bulk of our data around substance use and mental health. And I have a little snapshot here of a slide that we put together before the pandemic using the data from the 2016 and 2018 surveys. But we just learned recently that the Metro West Health Survey for 2020 has been postponed to the fall of this year, to the fall of 2021. So that that put a little strain on our ability to know exactly what's happening among student behavior. We did try to reach parents last spring. We put out a survey, the Youth and Family Services Department and our department teamed together to put a brief survey around mental health and substance use to ask parents what they were seeing. Mental health and emotional health were their primary concern, but again, this was back right at the beginning of the pandemic. So we don't have as much current information on their concern level at this point, but we know from anecdotal reports that parents are worried about their children's mental and emotional health. And in terms of substance use, when we queried them last spring, the majority of them were no more or less concerned at that time. But we're concerned. We know that from the rates that we saw on this Metro West data screen on the left, those numbers just don't go away. So part of our efforts are to keep pivoting to see how we can respond to the needs of our youth and family, especially now with mental health. Could you just advance to the next slide, please? So some of the initiatives that we have been launching through our work, through the coalition, the Substance Prevention Alliance of Needham, is to partner with other organizations. So just last night, for example, I know these aren't really meant as publicity shots here, but just to have as reference points, the far left screenshot was an event that we hosted last night. We had 170 people on this call, and it was a focus for middle school parents to help them navigate screen time and digital socializing for their youth as a way to really sort of allay a lot of concerns parents have, not only around this and how it impacts their child's mental health, particularly when we talk about digital socializing. So the response level was tremendous, and we can see there a need among our parents with respect to that. We partnered with BI Leahy Health and the PTC at the middle school. And then just quickly, a couple of upcoming events that we are networking with our cohort coalition in Natick, the Natick 180 Coalition, Cannabis in the Teen Brain. We are, next month. And then to follow that in April, we're having Michelle Lipinski, who's the principal of the North Shore Recovery High School, come as a panelist, a featured speaker for supporting youth who use substances. So sort of a two-part series, if you will, with the Natick 180 Coalition. And then I do want to recall that back in the fall, we addressed youth empowerment through adult connections. And we know that youth who have at least one trusted adult in their lives are less likely to use substances. So we brought a speaker in last fall to help empower parents, empower youth by creating connections with them. And that was very successful as well. So those are just a couple of the ways we're trying to support youth and families through direct work through the coalition. If you'd like to advance to the next slide, the last one. We will, of course, turn back for more data. One thing we are talking about right now is the parent survey that would typically be held this spring. We're poised to do that, although we are working with our consultant to evaluate what changes, if any, may be necessary to that survey given the pandemic climate for the last year. We are moving ahead with focus groups. We haven't done those in a few years, and we find that that can be another way to get qualitative data from our youth and parents. We're planning those this spring. And then, of course, as I mentioned, we will have ultimately new data from the Metro West Adolescent Health Survey it will be the first online administration of that to grades 6 through 12 in the fall. Can I answer any questions for anybody or?
Any questions from board members?
Thank you.
Thank you. I won't drag things out any, but that was very helpful. I know I signed up for that event and missed it last night, but I'm glad you held that. It's informative.
We'll send the recording.
Yeah, great. Okay, so unless there's anything more on this topic, I think we could move on to farmers market. If I don't know, I guess they're looking for guidance for the summer. Is there any sort of background for that?
Yep. So I just got contacted by the organizers. So they were just kind of reaching out. I was able to work with IT to get the application for this year on Viewpoint Cloud, which is good. So that's live now. So basically, we just wanted to ask what the board's opinion was moving forward on if we're going to allow for live music or if that's something that we should wait closer to when the actual market is. It was just because they had contacted me already. We were already agreeing to use similar rules to last year, not really changing the operation too much, but just wanted to know what the board's opinion was. And something came up yesterday that I promised the vendor that I would ask. So we have been pretty strict with requiring mechanical refrigeration for our vendors to keep products that have to be under 40 degrees cold. This vendor, I feel like it might be a financial barrier to have that as a requirement. The mechanical refrigeration, she brought up that she's done multiple markets with her. She bought high quality coolers with ice, uses a temperature log to make sure everything stays below 40. So I also wanted to know what the board's opinion was on using ice as refrigeration rather than making them buy those expensive plug-in coolers.
Is that something you feel like you could monitor if they did that?
So we had a fish vendor in the past that she was kind of grandfathered in from years past, that she always kept a notebook keeping track of the temperature of her product. So if they can show us that they're continuing with that temperature log, I feel like it can be managed. It was just because it's come up before that we've asked them for that mechanical refrigeration. I feel like that we might be one of the only farmers markets that are making people buy the plug-in coolers. And those tend to be expensive.
You know, as long as the temperature logs and the requirements are similar for the maintenance of temperature, I don't think the mechanism of refrigeration necessarily should matter. We just want to make sure the food's cold. I don't care how they do it. But I think the requirements in terms of, logging the temperatures and, whatever type of quality assurance that we're doing stays the same, regardless of the mechanism.
Steve, your mic is very quiet, just so you know. You're hard to hear.
Yeah, I would agree with Steve on that. What is this person selling?
Kombucha.
Oh,
So it's a drink, fermented drink.
Yeah.
The other thing I could add too is that we'd have to be very strict with like a protocol with, okay, so what happens on a hot August day, 95-degree weather, and you have no ice, so they'd have to agree that, they either shut down the booth and have to leave or have a protocol to have more ice delivered, or how that's going to work. We'd have to, make sure they submit something like that, which I think would be a good extra catch, like an agreement,
Yeah, and if the temperature should rise over, a limit, they're shut down for the day, because you don't know if there's spoilage for, all of their material, right?
Mm-hmm.
So, I think that's the risk that they take by, using ice as opposed to mechanical. But, if they're willing to do that, I don't see why we shouldn't be willing to accommodate them.
Perfect. And then to go back to the original proposition was, would we be looking to allow for them to do live music this year and keep the same rules as last year?
I would say we need to wait closer to the date.
Okay.
We have no idea which direction COVID is heading right now. If we have enough vaccination performed locally that our rates are getting, down and under control, we might be a lot looser than where we would be right now. If they ask for an answer right now, we are, while we're coming down, we are still where we were in December, which was alarming because we were rising pretty rapidly. So we would say no. So if they want an answer now, that's the answer they're going to get. I would suggest that we wait until later.
Yeah, I agree with Steve.
Yeah, it's fine. I mean, I think what we had last summer was more, I felt it was more stringent than needed. So, I think that would be the baseline. And then from there, it's whether things would be looser, but.
Yeah, but also include with that, as things change, especially as we move on in the summer, we may have a significantly larger proportion of the population vaccinated and rates going down, and then we would be willing to entertain a change.
Perfect.
Okay, so now we're on to tobacco regulation updates.
I didn't see a copy of the regs in our packet that I received from Tim last night.
I didn't either.
Wasn't any. I don't believe there was any. Diana was.
Oh, maybe I forgot to add it to the folder. I can email it to you.
What were the two issues? We addressed it in the last meeting kind of in detail, right? And we okay.
I think we just had to button up the fine schedule.
Diana, if you have it, you can just start screen sharing.
You could share, yeah.
I don't have it on I'm on my iPad right now, so I can't
Okay,
share
if
it.
you email it to me, I can share it.
Yep.
Okay.
But basically the changes there weren't many changes from the written version. I think it was just to bring up the topic again to see if you guys had time to digest and see what was actually going to be accepted versus not. It was basically the same document that was presented in November. There wasn't major changes. We just wanted to kind of see what was getting finalized. So the fine schedule was a big question. I don't remember the other big topics.
We retired some permits too, right? So those were sort of the two biggies that I recall.
And then there was some wording on DJ's sheet that he submitted last time that we were looking to adopt just to get it up to where the state regulation.
That's right. Mhm. Are we waiting to pull that up or should
Yeah, I'm
we?
sending it.
Yeah, take your time. Sorry, I was just checking.
Maybe while we wait just a moment, I could give a brief update about the budget. The town manager's recommended budget did not include funding for the public health accreditation warrant article. It did include funding for the requested warrant article that would provide $50,000 for the board to retain independent experts when there are large-scale utility projects like the Eversource Underground Utility Project or some of the Verizon small cell site installations. So that was recommended for funding. All of the sort of operating budget submissions were, of course, approved. Those were very minor. Those were generally minor adjustments related to step raises and slightly increased cellular data costs for people being remote and that sort of thing. There is a sort of omnibus, and there's a debate right now between the town manager and finance committee about whether it would be a reserve fund transfer or a warrant article or a combination. But there's an omnibus article about. Sorry, I thought I was going to sneeze, but I guess I wasn't. COVID costs, not just public health COVID costs, but costs from the schools, costs from other town departments, especially building maintenance, which has done the HVAC upgrades on all town buildings and testing and adjusting and balancing, as well as a lot of the supply purchases, PPE, hand sanitizer, that sort of thing. So right now there's that sort of public health warrant article was pulled into a larger warrant article, and there's discussion with the finance committee about whether that should be a reserve fund transfer or a special warrant article. So the main budget was recommended by the town manager and was also recommended by the finance committee. Accreditation still didn't get passed, and I think maybe we need to go back to the drawing board because that's many times we've tried with that and it hasn't moved forward. But the experts, fund for experts did get passed. And will be recommended at town meeting.
Yeah.
And
well, I think that's important. We get that fund to provide us with experts when we need it. And maybe we need to figure out another tactic for dealing with accreditation. I mean, I continue to believe it's important, but maybe we need to change our approach to getting the funding.
Absolutely. Okay, so if it's okay, I'll jump back and share my screen. And Diana, is there a particular page you want me to scroll down to? Is it?
But that letterhead is missing 2 of our board members, for one. I just noticed that. Rob and Christina aren't on there. So.
Okay.
Old letterhead, I guess.
And Diana, was there a particular section you wanted?
That's what I'm trying to find. I think you keep going down.
Okay.
We had, so page 10 is about the retiring of the permit. And then page 14 and 15 have the schedule, the fine schedule.
I can go back to page 10 for just a moment. I mean, I know what you said, but I'm just looking at the number there. Okay, fine. Yeah, I just want to make sure the number was correct there. 6. Good. Okay.
So right now we have no unused permits. All of the 6 permits are currently in use, and we have, over the last 3+ years, I think, retired 6 other permits, which is a good thing. There's limited options for sale of tobacco in the community. 14 was about the violations, and there are state violations and there are town violations. These are the first section, T1, is town violations. The second incorporates those sections of Mass General Law listed at the top of page 15, and provides the violations that they hold in state law, which is $1,000 fine, $2,000 fine, $5,000 fine. So what the board had decided at its last meeting was that state penalties will be in addition to local penalties.
Correct. And then we have the option to waive whatever portion of the town penalty we choose to do, because we can't waive the state. So
Correct.
My expectation, for instance, is, for a first offense, we're still going to, have the 7-day suspension. We can decide if we want to, fine people, $1,300, $1,000, or $300. Right? Because it could be the state plus town, just the town, or just the state, or none at all.
Yep.
So we have a fair amount of discretion doing it this way, which has its pros and cons, as you know, Dr. Cosgrove.
Oh yes, I know.
So
Gotten bitten by that one a few times.
Yeah, so I'm not sure how much flexibility we want with this.
Can you, what do you mean by the pros and cons?
Well, we have taken traditionally a very hardline approach with this. We regard this as something that's critically important for the community's health. And so when there have been violations, one of the ways that we have made sure that, there really is excellent compliance is we don't waive the fines. Occasionally we have waived the fine. We never waive the suspension. Because that economically is far more painful. I think we have, on rare occasions, waived the fine. There was one occasion when we waived the suspension a couple years ago because we had, I think, 4 or 5 vendors simultaneously fail a check. And that turned out to be a mistake on our part because, you know, the next compliance check somebody else failed, and, you know, and we went back to our, you know, not being lenient at all. And there was, I think, justifiable consternation as to, you know, why did these other folks get off and, you know, and I didn't. So I just wonder if there's going to be an issue with the fines. You know, right now, the way we have this set up, first offense would be $1,300 plus the 7-day suspension. You know, the $1,000 of that is non-negotiable, right?
Mhm.
We have ours now. We have a $300 fine in place because the state didn't have fines before that we were, you know, enforcing. So, you know, one of the questions I think that's going to come up is, do we waive our fine in lieu of the state's $1,000? When do we do that? When do we not do that? And obviously, people are going to come to a hearing asking us to waive everything that we can and just have $1,000. And I think, you know, traditionally this board would probably say we're not going to waive the suspension, but there's going to be some discussion over waiving that $300 from the town on like a first offense, and I think that same will be for, you know, second and third and so on. So it's just a question of how do you apply that fairly to any of the vendors who may be out of compliance.
And do we know how the 1,300 compares to lost business on the 7 days? Like, I mean, is this really, I mean, $1,000 is a lot of money, and 1,300 is a lot. I mean, I understand. I don't want them selling tobacco to kids, but
I think the last week in business equals to like 5,000 or 6,000. I think it's a substantial.
much worse.
It depends
Yeah,
on
but
the
whenever
vendors.
we try to get the numbers too, it's hard for them to give us a hard number of what
Yeah.
actually is happening. But I know they've already experienced a loss once we took out mint menthol, which made sense.
Mhm.
Yeah. I mean, I think that how much they lose obviously depends on the size of the vendor, and what their regulars weekly sales are. But some of the places that sell tobacco, I don't think they sell very much.
Yeah, so the ones who don't sell much, the fine is much more important than the suspension. But in general, the suspension has always been the important portion of this.
Yeah, because if you go to one of the gas stations, they have very minimal, like one of them, they just do it because they do have regulars that come through, but it's really not a lot of product in there. So it would be a huge loss.
Yeah. It's like the gas station in the center of town across from St. Joseph's. I mean, they have almost no stock in there at all.
Mm-hmm.
Is this going to be sent out so that we can do a final review before we vote on it?
I think we should see it before we vote on it. We have a meeting coming up in 2 weeks. We could put that on the agenda, couldn't we? I know it's COVID, but
We could certainly put on the agenda for the COVID meeting or for the next board meeting, which is in early March.
Yeah. How critical is this to get this?
It doesn't have to be passed right away. In fact, if we did want to vote on it, we would need time to notice it. So it would probably be better to wait for later in March.
Okay, let's wait till the next meeting, I think.
Okay.
In the sense that I'm kind of leaning towards here, just to give people an idea, would be that, you know, we adopt the state for the basically the higher of the two fines, not be additive with the fines, and keep the suspensions. You know, we have to word it in such a way that should the state change, you know, their tune and they, you know, get rid of their fines, that ours would be maintained. You know, that's kind of where I think, you know, might make sense. So a first offense would be a 7-day suspension, $1,000 fine, and sorry, we can't waive the $1,000, and the 7 day is what's coming from us. Something like that. I'm not sure the best way to codify that into regulation at the moment, but maybe if we all get a look at it, we'll be able to do that before next month.
Okay. That sounds great. Tara and Diana will follow up with the red line version.
And
sorry, go ahead.
This language, Matt Wilson's already seen this, hasn't he?
DJ from the Mass Municipal Association.
DJ, sorry, yeah.
Yes,
DJ.
he has, but we'll run it by him again because we do always check in with DJ and Cheryl.
Okay.
MAHB.
Okay, thanks for that. I think it was worth looking at it in more detail. Okay, let's see. So now we're on to COVID update, monthly report. I don't know who wants to take the lead on that.
So I think Hannah and Tiffany will take the lead on that.
Sure. Should I can share my screen. Does that work?
Great. Yep.
Let's see. Can everyone see that normally?
Yep.
Great. Okay, so COVID cases in January. Just to kind of zoom back to look over the year, you can see cases were really going up to a peak in late December, early January, but they have started to come down a bit in the second half of January. You can see the cumulative case line starting to level out a little bit. In terms of the rolling 7-day average, you can see the same kind of hitting a peak right at the turn of the year, followed by kind of a bit of a decrease, but cases are still quite high. Then to look at cumulative cases by age group, you can see 65 plus is by far the highest, and that's mostly driven by the early months of the pandemic, where the cases were just so high in that age group. Also of interesting note is that the 0 to 18 group, while they until like the fall was the lowest age group, they have kind of really increased their rate starting in mid-November and are now the age group with the second highest cumulative case number, which is interesting. Again, to look at age group breakdown, January was quite similar to December. 5 to 18 is the biggest group just in terms of number of cases, and it's pretty evenly split between the others. In a few slides, I think maybe the next slide, we break it down as a rate, so you can get a better sense of it standardized by population size. So yes, this is the average daily incidence by age group. So you can see in March, April, and May, 65 plus by far had the highest incidence, but since the fall, this has shifted and the 20 to 34-year-old age group has had the highest incidence. But when we break this down by sub-age groups, looking over the last few months, you can see it's actually teenagers and the early 20-year-olds who have had the highest rates.
Right, so I'll make a point. That's high school age.
Yeah.
Right? Okay.
And presumably some who might be in college. Unfortunately, the way that the age groups are broken out in the town census data, the age cutoff is 15 to 19, so we can't kind of break it down smaller than that to see, which would be more likely to be high school versus college. But it's, I think, interesting that the 20 to 24-year-old age group is also kind of trending quite similarly. Just to look at gender breakdown, it's been fairly close to 50-50 throughout. In January, there were slightly more cases among males. So now to kind of zoom in specifically to January, there was a fairly constant growth in cases throughout the month. You can see that towards the end of the month, the second half, things start to plateau a little bit. Cases are going down slightly, but are still at a quite high level. Like I had mentioned, gender, close to 50-50, slightly more male this month. I'm going to actually skip over these in favor of this. So this is looking at comparing the age distribution of Needham's population to the age distribution of COVID cases. So we can see where there are kind of disproportional rates of cases. So you can see where the blue bar is higher than the green bar. That means that population group is kind of overrepresented in the cases. So like the incidence rates we're suggesting, we're seeing that in the 5 to 19 age group, and then the 20 to 34 age group more drastically. Whereas the other groups, their share of cases is quite close to their share of the population. And then when we look at this as an incidence rate, so the red dotted line is the overall rate for the entire town. For January, it was about 38 cases per day per 100,000. So the age groups who have a bar above the line, that's indicating that they had a higher incidence rate than the town average. So again, we're seeing that in the teens and young adults. And then to break it down further into sub-age groups, this again, comparing proportion of cases and population, you can see among both the 15 to 19-year-olds and the 20 to 24-year-olds, their share of the cases is almost twice as much as their share of the population. And this is again reflected in incidence rate, much higher than the overall rate for the town, whereas younger children are at a much lower rate. And then looking at adults, again, we see in the younger end of the adult age bracket, the 25 to 34-year-olds have a higher share of cases. They're disproportionately represented by a bit. Whereas the 35 to 55-year-olds, their share of cases is matching pretty much exactly with their share of the population. Again, this is echoed in the incidence rate. You can see it's highest and above average with the 25 to 34-year-olds. And then to look at the 65 and over age group, again, there's not a lot of disproportional representation. The 85 and older, they have a 1% higher share of cases than population, which is actually less than I probably would have expected. The 65 to 74-year-olds are underrepresented in the cases, which is good. And then for the 85 and over group, when you look at the incidence rate, theirs is quite a bit over the overall rate at almost 50 cases per 100,000. So those are the cases. If there are any questions before I jump into the clusters.
So I just, I think just a couple of points to be made, obviously. It looks like we need to focus a lot of our prevention efforts on 15 to 25-year-olds. That seems to be the majority of the cases that, that are disproportionately represented. That's also going to be probably the last group that's going to be vaccinated. So my guess is that we're going to see, particularly with the larger, with the older age groups with vaccination, again, depending on how many shots we can get into arms for our population, that we might see, that start to diminish quite a bit. But we're not going to see that diminishing in the youth anytime soon.
And along with that, the 85 plus group, they're overrepresented. Presumably that part of it's because there's not that many of them in the population, but do we know why that is? Is that congregate care? Is there anything we can do to impact that?
Yeah, this slide is overall, right, Hannah?
Sorry?
This slide is overall the whole year?
No, sorry, this is just January.
This is just January. Okay, yeah, so that's mostly our congregate care living facilities, and particularly one because they admit COVID patients. So that's part of why that one's so much higher.
So like, what's the number there? Like, once you turn this into an incidence, you get a pretty unstable ratio, or you can, like, do we know how many that is in January? Like 20 or 200?
How many of their cases? Not off the top of my head. I'd have to look at their cluster.
So it could be like big error bars on that too, you know, to keep in mind, but yeah.
Yeah, we definitely look into breaking out congregate care, not, yeah, from the clusters, we saw 26 cases in congregate care, many of which would fall into that age group.
So it sounds like from the 85 plus group, it's not necessarily transmission that's happening in Needham. It might be that somebody gets hospitalized and then they get moved to a facility in Needham after hospitalization, and they happen to be COVID positive and they get accepted there. Is that correct?
Correct. Yep.
Okay.
As far as the cluster analysis, and maybe you can help me understand this, but if we know that the population that's driving infections is 15 to 25-year-olds, and most of our clusters are being assigned a household, I would expect to see some older adults, say in the 35 to 55 age group, who are going to be the parents of the young adults and the teenagers who have this, be infected. But we're not seeing that, right? Because we're seeing that they are actually proportionally represented rather than disproportionately represented. So I'm not sure why that's happening. Or are the clusters, I know that the cluster analysis, it's one of these things where you assign it, as opposed to necessarily knowing exactly where transmission is happening. You're kind of making a judgment for, where it's most likely. But do we have a good explanation for why, we're seeing transmission cases largely in the younger population, but we're not seeing that secondary bump in their parents if this is household transmission?
So you should be, Hannah, if you go all the way back to your first slide that had the actual cases, not the incident rate, you see a spike both in the high school, or it was all ages of school, plus the 35 to 50 range. And we do see that trend, but since you have more kids generally than more parents at times, or you have split households, it's not necessarily going to equal quite the same.
Got it.
But we do see that trend. That's exactly what we see. Either the kid gave it to the parents or the parents gave it to the child.
Got it. Okay. Thank you.
You're welcome.
But yeah, it is remarkable that, over half of the cases we're seeing in Needham be linked to a household cluster, and we're just defining that based on a shared address. So we can't really necessarily break it down into which direction it is going in, but there's definitely a lot of household transmission going on, and especially compared to, you can see there were, a handful of daycare clusters with just a few Needham cases, congregate care, again, 26 cases, which accounts for almost 7% of Needham's cases in January. But in terms of clusters, it's a lot of household transmission.
Now, the schools, weren't there 2 clusters, or was one in December? Because we had Sunita Williams and we had the high school, right? And I think there was something like 30 cases at the high school, and I'm not sure how many of those were assigned to a cluster, and 1 at Sunita Williams.
Yeah, so there's been 2 in December, I do believe, and then we'll have some more for the February report. So.
Okay.
So those are clusters, and then just in terms of contacts that we saw in January, there were 321 school contacts and 104 just in the Maven system.
What does that mean? Sorry, could you explain that?
Sure. So the Maven system is just the state epidemiology system. So those are just general cases in Needham, their contacts. So 104 contacts in Needham. They could have been from a Needham case or a case outside of Needham.
So associated with a Needham person, I get it.
Yeah.
So
And then
So school age kids have 3 times or more as many contacts than a sort of normal age case in the community. Is that the general idea?
That is the general idea. However, depending on how busy we are, we don't necessarily put all of our contacts into the Maven system either. So this number is an approximate, not an exact. But yeah, that is the general idea.
So how many more would you estimate? How many contacts are identified just by the health department?
Like per household?
Well, if you were to add another source to this.
If I were to add my written so when I was doing contact tracing by myself, I never put a contact in because it was easier for me to have it on a piece of paper in front of me than try to retype it in a bunch of times. So if I were to give a wild guess, you probably have another, this is just for January, maybe another 50 or so onto that. That'd be my guess, but I haven't done any in January. So we'd have to check with Mary and see if she has more info on that.
Okay.
So that is my last slide. Don't know if there are any other questions on any of that.
Do we ever dig into sports clusters? I mean, I know the state is, doing some, in that meeting we're all missing at 9 a.m. on Fridays, but they've dug into some of the sports clusters. And I know we were under the impression previously, I know I was, that a lot of the transfer was occurring not on the field or court. And that is not what the state is finding in their cluster analysis. They're finding like 75% of cases related to sports are from one setting. And so it is really on court / well, not field. Outdoors, I feel like is different. So I think when we were in the fall, it was a different scenario. But what I'm getting at is better masking. You see these basketball players with the chin strap. Across the board, I think some guidance on better masking, making it fit better. The whole two masks, I think, is a little over the top, but one well-fitting disposable mask that you tape on or something. There's good info out from CDC now, so it would be great to share some of that. Maybe, in one of our updates, it would be already curated material we could put in there. Any other questions or comments?
Well, I am thinking a little bit more about, the schools opening up to, full-time K through 2. And, I was just hearing from some parents that some of the schools actually do indoor mask breaks. And I wasn't aware of that because we don't do that at ours. And I think that's something too, that in our meetings with the school committee or Dan, that we should advise against that. That in the classroom or in other spaces, they shouldn't be, because in addition, they're also, having snacks. The little ones are having snacks without masks in the classroom, and then they eat lunch, distanced and whatever, but still in the cafeteria. So I think there is enough risk already that we shouldn't be doing indoor mask breaks.
I don't know where we are with the state assistance program for school testing, but it seems that, based on the age distributions that we just saw, if we're going to take a focus, it should probably be high school first, rather than the elementary schools, just based on the incidence.
Yeah,
I think that's good. Yeah.
Right. The schools are not pursuing student testing in any shape or form.
Does that mean that we can't pursue student testing in any shape or form?
Well, how would we implement it?
Yeah.
I mean, our staff are flat out, and I would focusing on vaccination seems to be the priority.
Vaccination should be the priority, but these kids aren't going to be in the vaccination pool for months, right? I mean, let's face it. So the question is, are we doing everything we can in the school system? Because that is where the transmission is, some of it's occurring, or we have suspicion, in the high school level, considering that they just closed down for 10 days and had 30 cases. The state has been offering funding to do this. What do we know about the state funding? Because if the health department gets the state funding, you know, the question is, can we implement that, or we provide the funding to the school department if that's the issue? If it's a political issue, then the question becomes whether or not under Chapter 111 we can force the schools to do it if we think it's that important.
The answer to the latter is, it appears to be no, because I asked Cheryl Sabara, like you had requested, Steve. She said the board does have, powerful authority under Chapter 111, especially to sort of investigate nuisances, but the governor's emergency orders specifically gave authority about school opening and school status to school committees.
Okay.
So I think we'd have some difficulty being too much, we have to be careful there. I think certainly the schools are not trying to bring additional high schoolers back for more in-person learning. The plan was to add kindergarten, first and second grade, which we know are far lower risk for transmission, to add them back 4 days every week instead of 4 days every other week, and to add some live, I forget the words they're using, but live virtual instruction instead of asynchronous virtual instruction for 3 to 5, grades 3 to 5.
So here's what I might suggest then, if we can't, if we can't force the issue. First off, if they're going to increase exposure, we may see an increase in rate. We don't know, right?
Sure.
But I think we could make a formal recommendation on the record to the schools that they test.
So first I'll say the state funding is for 6 weeks. So that doesn't get you through the school year. And for the rest of the school year, that's in our minutes. It's like $800,000 probably.
Right, but we were only talking about doing a single point in time just to test whether or not the protocols currently in place are actually working. We weren't talking about doing continuous testing. So we don't know that that's going to be as helpful as, just getting that single point actually gives us some data that what the schools are doing actually is effective. Because if it is, we're done, right? If it's working, it's working.
So what's your decision point on that one? I don't really want to go down the rabbit hole on this too much, but I mean, so what's high? So we screen the whole high school. What's a high number? Right? I mean, I think that's you test when you have a benchmark.
Well,
or you keep testing to compare to develop your benchmark, correct? I mean,
well, I think the first thing is to demonstrate are there cases in the high school period. Right now the supposition is that there are none, that this doesn't happen in the high school, and I think that's wrong. I mean, we don't even know what the incidence in the high school is to begin with. We don't know if it matches the population incidence that we're seeing. Based on the slides we just saw, we don't know if it's higher or if it's lower. I mean, that's important information to have, and we don't have that right now. And I think further testing might be based upon that, but we are right now flying blind entirely, and that's kind of a dangerous place to be.
So I understand what you're saying, and I do agree. I think, we haven't yet talked about our vaccination clinic in detail, and we do have one or two slides on that, but we're pretty flat out running our vaccination clinics. I spent a lot of time, and Kathleen spent a fair amount of time doing research and talking to the schools about different options for testing. And they approached us in the context of we know that distance learning doesn't work well, especially for the youngest students. How can we get more younger students back? And when they talked to their teachers, the teachers union said, you have a binding agreement that you signed with us that you will meet these conditions. The answer is no, we won't, because that was signed back in August when community transmission rates were like 4 cases per 100,000. And now they're in the 30s. So that the school union basically said, if you can come up with a testing program for staff to reassure staff that it is safe and that if they do get infected, it will be detected, that's how we get the younger learners back.
I'm sorry, we get younger learners back by testing the teachers?
Because the resistance is, you are asking us to buy, so CDC has said repeatedly, close contact is 6 feet or less. Right now, they're a little bit less than 6 feet in most instances. If you bring back more kindergarten through second grade, then you're at 3 feet or maybe even a little less in some instances.
Right, and I looked at that CDC report as well. The CDC guideline was based on this study out of Wisconsin,
Mhm.
with small classes between 12 and 20 students who were socially distanced greater than 6 feet at all times. That
Yep.
is not this, in well-ventilated areas. And that is not the case that we have in Needham. I mean, you're comparing apples and oranges there. And I was a little bit surprised that they extrapolated that to the nation. Because when you actually look at the data and how they did it, that's just not the situation you have everywhere. Now, if we can meet those conditions that they have in Wisconsin, terrific.
We can't.
That would be a safe way of opening. That's been demonstrated, but that's not what that's, as you just said, I mean, they're talking about 3 feet distances. That's not what they did in Wisconsin.
Yes, and so the staff feels that that's an unsafe working condition. And when the administration discussed it with their union, the union said, what can you do to reassure us that this is not unsafe? And the union said, well, then we need teacher testing to know that our staff members aren't getting infected.
I'm surprised only because, the only way we're going to know that is after they all get infected. So it's after the fact, yep, we know now it's not safe. And by the way, some of you are, hospitalized or what have you. That's,
Well, I think the hope is that especially with the younger students where data shows pretty clearly that they're much less likely to spread COVID, especially when you're talking 5, 6, and 7-year-olds, that this testing program would find infections if there are any, but that hopefully because of the population, there are not significant number of infections going from students to staff. To date in the schools, and Tiffany or Hannah, please correct me if I'm wrong, I don't know if we have yet a confirmed instance of a student infecting a staff member. We have a couple instances of staff members infecting students. So we think that testing for staff members will alleviate the concern from staff members and would allow them to get the highest need learner back into the classroom. But again, this was the school's plan. They wanted to come up with a plan because they realized the educational needs of the youngest learners and the social, emotional, and mental health needs of the youngest learners were not being met, or they didn't feel they were being met sufficiently with the hybrid program.
how
Has
often
the
do they
school
report
started
to
to?
students? Sorry, the teachers, twice a week?
Once a week.
Once a week.
Tim,
That has
Tim,
started.
can I say something as
Well, I
like
think
our,
Rob looked like
Okay.
he was trying to say something first.
sorry.
No, just has the program that the school was going to do with the voluntary testing of teachers, has that started?
I believe it's 2 weeks away. So I think it's starting, Kathleen, maybe I'll have to check with Dan, but I know it was starting the end of February. I believe.
Yeah, that's right.
I mean, I think there certainly could be frustration here. I think in part, if the board doesn't feel this is the best approach, then the board should interact with the other town boards, which is the select board, the finance committee, and the school committee, and say, we think this is the way to go. That's always your purview as elected officials to make that argument. I think right now, the public health division is doing our best to support the schools when they ask for guidance and public health insight. And we're doing our best to do the vaccination program, but we don't have the bandwidth to be all things to all people, and spinning up a huge testing program would be a lot of staff time and effort, not to mention a lot of money that has not been given to me in my budget. So I'm not sure how we can move that forward.
Right. Tim, can I just share from my Medfield Board of Health? And I ask, and then I keep talking. In Medfield, they did the Abbott test, the school nurses, and now they are doing the pool testing. Unless parents opt out, every student once a week, I believe. And parents have asked the Board of Health, I'm a member, to make a recommendation and vote on whether or not students should be back to full in-person learning. They have a plan for the younger grades to bring the students back full in person. Right now they've been at hybrid, but I say this because for a while, the school nurses, they've done the Abbott, which is controversial, but now we'll be doing the pool testing as one component to educate parents and staff, and for collective bargaining and conversations on what actually is happening in the school, because like Needham, we have our highest case rates lately are our students. And although we haven't had a case of transmission in the school, they're in our community the highest. So I just want to say that I work with 4 towns with my grant, and it's frustrating to me because across the state, different communities are doing different things and with different levels of funding. So we have our school nurse is now on our Board of Health, and she said, I've got 5 weeks of money for this program. I didn't realize it was 6, Kathleen, but we'll be in a conundrum. But the it's a commitment in Medfield for students, for pool testing, for staff and students for at least until the money runs out, to give a snapshot of what's happening.
Yep, and the schools did not choose to avail themselves of that state program, and that was a choice. They did ask my opinion and our opinion. They also had their own concerns about the bandwidth of staff, including their school nurses, who do quite a bit of work helping us with contact tracing, or have done some work helping us with contact tracing. And we've recently sort of indicated to them, Tiffany, you can jump in here, that the volume of school cases and the complexity of school cases requires additional commitment time from the school nurses if they're going to be resolved quickly.
Correct, and they have agreed to that, thankfully, and we're appreciative of that, because otherwise we would have to start sending some school cases to the CTC.
So is the issue a money issue here?
I think yes, that's a big part of it, but it is also like a logistical problem. Like, so now they're going to be offering the program for the faculty or for the staff and teachers. And then the problem is to then overlay a second entire program, which would what the state testing, it's a whole different method. The program that's going for the staff is saliva testing. You do it home, you drop it off at a central location or at your office at the school. But this is a swab system where it's developed for classroom. So you get a hit in the pool, the whole classroom and the teacher are out. And that was not a model that was favorable to, at least it appeared, to the school department.
And we made a recommendation of some sort regarding this?
We didn't. I helped them assemble information about testing services that were available. That is all I did, because I had already been investigating, see the various vendors that were available. So, and then the school department pursued that. They looked at the options that were out there.
Right. Testing costs are down to $50 a pop right now, commercially.
Mm-hmm.
All right. I don't know if you can get it for less than that.
No, pooled testing is like $15 a pop, basically.
15. Okay. Mm-hmm. So pooled is going to be the cheapest, but individual tests, I mean, I can get them for $50 now.
Right. 50, yeah, which is really, that's a lot of money for 6,000 people in the school district.
Yep. It is. But as I said, is this a money issue? Because if money buys us manpower, then we could get this done, right? I mean, the select board has said that we should go to them if we feel that that's the right way to go, and ask for the money. So that's my question. I mean, if this is a money issue and you're saying, gosh, we don't have the money, then this board, as Tim suggested, should go to other boards like the select board and say, we think we need to do this, and this is what it's going to cost. Now, if they say we haven't got that, so be it. But we have gone on record. It's not sitting on our, not sitting by doing nothing, but making a recommendation, and at least that's on the record.
I'm not convinced that it is. I mean, the communities that have done this, they found, maybe a handful more cases than we do. It's for an extraordinary effort and cost. And I don't think that the select board, that there's a big $1 million fund waiting to do this testing.
Oh, there may not be, but at least we should ask. All right. Particularly if we're going to go back to K through 2, which I agree with the data, I think it makes sense to try it, right? But to not test as we do that, I think, is a mistake. because we are not following the CDC guidance as we go forward with this. Okay, we're just not, right? CDC guidance, I would say, fine, we could get away, maybe saying we don't need to be testing because that's already been done elsewhere. But when you start going to larger classrooms, not distancing more than 6 feet, with all of these indoor breaks, you've got much higher risk going on, and we're not testing, and that I think is a mistake.
Okay. I mean, I think it's both a question of the time for staff and the sort of administrative and logistical burden of sort of any program getting off the ground, as well as a question about the costs, because as we indicated, a very modest program is in the, a very modest program like the staff testing program that's proposed, which again is the staff, it's not the entire student body, and it's once a week, not multiple times a week, is $400,000 approximately for the remainder of the school year. So I think that they're already trying to figure out how they come up with that money, because they're already running a deficit. So I think it is both a financial question and also a manpower question.
Right. Because
question.
part of the question is, do you have to do this for, the whole rest of the year? If you're going to test teachers, yes, probably. But again, I mean, I'm trying to make the argument that I think we need to test and see whether or not the protocols are working in the schools. And if they are, then you don't need to be testing, so frequently, and you can lower your costs.
I think that's possible. I don't know if that's the route the superintendent is looking to go, and I think the only person that can tell the superintendent, or the only people that can tell the superintendent that that's not the way to go, is the school committee.
So do we need to have a meeting with the school committee?
If the board wants to, we can you can either meet with them individually, or we could try to have a joint televised meeting, although with a joint televised meeting, I think people, some might be reticent to fully share their opinions. So we'd have to figure out the balance on that. I do know that Dan works pretty closely with his school committee. I know the vice chair right now is Connie Barr. So I think Susan Neckis is the chair, or maybe Andrea is the chair, I forget which. And Connie Barr is the vice chair, and Connie is a physician, a primary care physician. So I think if they have concerns about the superintendent's approach, I have not heard them.
So maybe I'll reach out to Connie, but I mean, I'm thinking I should just bring something as a motion at our COVID meeting for us to vote on and go on the record, one way or the other, regarding this. Because I think it is important that we make sure we're doing everything, from our standpoint, which is to protect the safety of the town and its inhabitants.
Okay.
So we're going to get at least a little bit of a proxy by testing the teachers. It's obviously not maybe what we would want in terms of testing everybody, but I think, as we talk about this, we also would want to consider, if we were to pursue testing of students, would we focus that on the higher risk areas? And I mean the high school. That might be one way to get around some of the manpower issues, some of the cost, because you're only dealing with one school. And that, by our numbers, seems to be where the highest risk would be.
Right, both with our numbers and the national numbers say that the risk of transmission amongst older students is the highest. So I do realize we lost Ed in our discussion. And I know that some people had said they wanted to try to impromptu. Very, very briefly, if I could, we have given out as of last night, not including this morning's clinic, which is currently ongoing, 1,850 doses. Our clinics, which are open regionally, have produced about 23.5% Needham residents. We were supporting Dover and Medfield, and they are the third and fourth most, the highest numbers for communities. That other group of 855 amongst the first doses is really, really scattered throughout the state. It's Barnstable, it's Bourne, it's Brockton, it's Great Barrington. It's literally all over. So I think that does show that we're making this available and we are attracting a broad group. Tiffany came up with, and it's a very complicated operation between first doses and second doses. And right now we're managing both Pfizer and Moderna, a plan that is going to carry us through June for clinics. Tiff, do you know how many clinics that ends up being?
Yeah, I'll tell you. So we threw in 38 clinics, but that's first dose only. So times that by 2, so 72 clinics, plus potentially a 12-hour clinic in the middle of that. So that will equal 74 clinics total, first and second dose. Most of them will be 6 hours, except for that one 12-hour clinic that we may have to finagle somewhere.
And if we really like it, we're thinking of a 24-hour clinic.
He wants to be a drive-through. Yeah.
You want to be like a diner. You can get pancakes or an omelet at 3 in the morning and you're vaccinated. So board members, we can certainly follow up more. I can ask, certainly it'd probably be easier to get 1 or 2 members of the school committee to attend a future Board of Health meeting than would be to get the full school committee. Or the board members can approach them separately, elected official to elected official, or some combination of that. Is there a particular way you'd like to proceed in that front?
I can reach out to a couple.
Yeah, I mean, I think we reach, you want to know your answer before you get there. So I think reaching out at least initially individually, but perhaps inviting, a couple to the COVID discussion, even the next one, rather than the full committee, might be of use.
Okay, that sounds great.
I think too, it would be useful hearing from, members of maybe the Board of Health of a place like Wellesley that has undertaken something like this, and just hear their thoughts on it. I personally talked to Marcia Testa there a few months ago, but I wondered if, I don't know how you all feel about maybe even having someone from that group kind of, share their experience with this process.
I would certainly be happy to, although because there's always a little bit of a friendly rivalry, I think they are hoping to eventually get their 200th vaccine administered. So they've emphasized some things, we've emphasized others.
Yeah, and I've been watching their Board of Health meetings, so I've been getting the updates on their program. So I understand, and it is also, once you've done it, of course you think it's a great idea, right? Because you've invested all your money and time. Plus it's hard to end a program, right? So if you're, so if something is started, it's hard to end, I guess, is part of that question too. So if you have 6 weeks of funding and then it ends, how people feel, but something to.
One thing that I'm wondering, and Tim and Tiffany, the governor's recent guidance on, the partners of the 75-year-olds. I'm just wondering with the schools, and this is thinking out loud, do we partner teachers with seniors and get the teachers vaccinated that way?
So the problem with that is that when we have someone come to our first clinic, and he's done this in the middle, which is the issue, is we've signed them up for their second. So our second dose clinics are full and we can't add more people. So when somebody brings somebody, they can't add them. Plus, when we open up to the public, we have no way to moderate it in the prep mod. So what we've pushed out to people is if you're gonna bring somebody and you have not received your dose, you need to sign 2 people up, you plus them, because you must have an appointment to be able to get that.
Right.
The senior center has been getting a large volume of calls over the last day about people saying, hey, I'll drive somebody so that I can get my vaccination.
Right.
So they're trying to work through that process. But our clinic is definitely going a lot slower. Our signups, I just opened them at 9, definitely going a lot slower than they were last week. So we'll see what happens.
Yeah, because I'm wondering if we kind of worked through some of that backlog that we had, and but if that's a possible strategy, that that's our way, kind of to, because I think ultimately, you really want to reopen the schools, get the teachers vaccinated. I think that's ultimately what we can do, and that's probably the most cost-effective approach. It's just right now regulatorily it's difficult. So if we could maybe make that linkage, and kind of offer that out informally to the teachers and get them vaccinated, that could go a long way towards getting us to open up the schools fully.
So we'll keep that in mind. I'll present that to Jess, but again, they're also super stressed out. So adding to another pocket of trying to coordinate a 75-year-old with a teacher adds another realm on that. But we will keep that in mind for them, and I'll let her know that that's a possibility if she thinks somebody needs it.
Right. And Tim, what happened with the site at TripAdvisor that is not open to Needham residents unless they happen to be a Mass General Brigham patient?
So I did follow up with the state, and the state asked healthcare providers to vaccinate in network. They didn't want, because there's max vaccination sites that are open generally, they wanted partners and Beth Israel Lahey and the other sort of care networks to vaccinate within their network. Although they also announced today that basically they're not giving any more to healthcare providers for at least a period of time. I don't know how long that is. I think we're wondering or worried what that does to potentially our future supply. So we're concerned, and we're questioning whether that'll actually affect what local public health gets too.
I'm thinking it's actually going to increase our supply. That's my guess. I mean, I was talking with Denise about this a little bit earlier this week and questioning why the health systems were getting it, in part because they've vaccinated people who are not patient facing, backroom clerical workers are getting vaccinated before 75-year-olds and before others who, really realistically should be much higher up on the list. So that might be part of, those stories have been circulating. And I think that might be why they started cutting off the supply that way.
I hear you, and that makes a lot of sense.
I think there's a lot sitting there at the healthcare providers. Okay, so are we ready to wrap up at this point?
Sure, and just as a reminder, the board's next meeting is a COVID-focused meeting on the 24th of February from 7 to 8 p.m. So that will probably be, won't be with the full staff. And as the board indicated, I'll see if maybe Alan Stern, the school physician, or Dr. Barr, or someone else from the school committee would be willing to join in the discussion.
Great.
That'd be great.
Okay, I have a motion to dismiss, end the meeting. Motion to close the meeting.
Motion to close.
Okay, second. Anybody? Aye.
I'll second.
Somewhere. Okay, all those in favor, Rob,
Aye.
Christina,
Aye.
Steve,
Aye.
Kathleen, aye. Thanks, everyone.
Thank you, everyone.
Thank you.
Thank you, everybody,
Have a good day.
for all your hard work.
Yeah, thank you.